I'm going to try to keep it on time the next 2 days. Not my expertise. For those of you who know me, welcome. For those of you who don't know me, my name is Matthew Rodreick. I'm the Executive Director of Unite to Fight Paralysis, and I welcome you to our annual Science and Advocacy Symposium. Thanks for being here. Couple of things first. I want to welcome you, obviously, on behalf of U2FP. Nice to be here, home. This is our home base. For those of you who have joined us in other cities over the years, we appreciate you coming here. Also, on behalf of the University of Minnesota Rehabilitation Medicine, Institute, no, that's not an institute. I always want to call it the Department of Rehabilitation Medicine at the University of Minnesota. Leslie Morse, who couldn't be here this morning, she will be here later this afternoon, traveling back from a trip. So on behalf of the University of Minnesota, I also welcome you. They are our title sponsor. Very grateful to them. And we're very grateful to all of our sponsors for helping us to make this meeting happen. And particularly to help us keep it affordable for the SCI community to attend. So we're grateful for that. And also, briefly, I want to remind, because I just forgot myself, I want to remind our presenters to introduce yourselves with some visual cues. So I am a 6'3" white man wearing a black and gray shirt, blue eyes, and a very white beard of an old guy. So I would ask you to do that on behalf of our various communities with various differing abilities and different needs. So as a sort of matter of course, I would ask our presenters to do that and remind you to do that. A couple of other things, as I mentioned, I'm grateful to our sponsors. I'm also grateful to our presenters who are you going to hear from in the next 2 days for donating their time to come and join us, share their work, their passion, their energy on behalf of the SCI community. Few logistics I want to get out of the way first. For those of you who don't know, there's a thing called the Whova app. You should have gotten an email. It's an app designed for conferences. I see a lot of heads nodding, so I'm glad that you got it. It's a way for you to connect. There's also some information in there, like a survey, which we would ask you to complete for us. Helps us to know how this is doing. You can do it however you like at the end of the meeting, or you can do it after every presentation. That's number one. Number two, if you haven't already, over here on the far right is an art installation by an artist named Lynn Denio. She is the partner of a gentleman with a spinal cord injury for many, many decades. She's an artist. It is a beautiful, kind of visceral representation of spinal cord injury. Lynn and Doug donated it to Unite to Fight Paralysis in the hope to share it with the community. And just a little sidebar for anybody who's sitting here, we are looking for a buyer for this work. Lynn would very much like it to go to a place where people with spinal cord injuries come often, like a clinic, a rehab center, a center that's committed to spinal cord injury so people can see that and connect to it. I would encourage you, if you haven't already, go take a look at it. That artwork is also in your program, some pieces of it with a little description. So I want to point that out to you. The other thing on that Whova app that I mentioned, at the end of the conference, when we go to the Hilton, I hope they're listening, we have a letter drafted. For those of you who, I know I've already talked to some of you who have challenges in hotels with accessibility, roll-in showers, access, navigating a room. It is a persistent problem for an organization like us that runs a meeting and has lots of people coming who use wheelchairs. So please sign that letter. You can if you agree to it, but we're actually asking them, please consider the next time you renovate this hotel or a floor or 5 floors or 10 floors, put zero entry showers in. It's a no-brainer. Who takes a bath anyway in a hotel bathtub, right? Ew. Sorry. That's aside. Lastly, and I think, Lucia, I noticed there's a person up here doing ASL. Is that who we've contracted with? Yes? Excellent. That's sort of, hi, welcome. Thanks for being here. That's, again, a part of this recognition of differing communities, differing abilities. And I want to give a special shout out to the Craig H. Nielsen Foundation for providing a little extra resource to do that. As a matter of course, the realization, kind of like I just mentioned with the hotel, right? Like it's not, it just should be what we do, and recognize that not everybody has the same abilities, and let's change how we do things. And so that's a little bit of reflection of that. Couple more things before I want to give you a little quick message. One thing, if you're unfamiliar with U2FP, please just check out our table out there. You can find some information. There's QR codes, and you can find out a little bit more about what we do and how to join our work, support our work, etc. And related to that, if you're unfamiliar, we do a podcast, myself and Jason Stouffer right there, who's raising his hand. It's called CureCast. I know some of you listen to it, but we're doing something different this year. There's a little spot out there where we're going to have an ongoing sort of microphone available to you. You want to be on our podcast for a few minutes? Jason and Julie, our podcast producer, would like to interview you. So you could come and be on the podcast, put your voice here. There's a little poster out there. So I know Jason would love to talk to every single person in this room, but even if you're shy, so go find them and be on the podcast for a minute. Okay, I hope I have enough time. I'm going to do something. I just want to share a couple of remarks. I do have enough time. Perfect. You bring up that slide, guys. I want to do something a little different. For those of you who know me, I'm always kind of playing around with metaphors to articulate things that sometimes aren't so easy to articulate. So I'm going to do that with this thing. Can you hear that? Oh. Harmony. Most guitars, conventional guitars. Anybody play guitar here? No? Nobody? There's 6 strings. And they're tuned to those notes. E, A, D, G, B, E. Sorry, I got a lot of stuff here. But that's just for a little thought experiment. There's 6 strings here, E, A, D, G, B, E. And for our purposes, let's suggest that each of these strings represent stakeholders in our community. Researchers, clinicians, funders, regulators, industry, and people with spinal cord injuries. And they don't sound very good, do they? There's a little disharmony happening in this guitar. Can you hear that? Sounds terrible. You got to tune this thing in order to make it harmonize. And in order to do that, one of the first things you need is to know what you're tuning to. So I don't know if this is kind of weird rabbit hole, but people who tune guitars, they recognize A440. It's the hertz, it's the audio frequency that was decided to be a standard in the 1920s by the music industry. And it's what this little device here I'm using helps me to organize the sound of these strings to that standard tuning that you all recognize. So I'm going to use my little tuner here, my tool, to get this thing tuned. And what you can't hear, but I can hear, is so you need tools, like I just explained, but you also need good ears, because sometimes you don't have all the tools in front of you readily available. So you need good ears to know when you're in tune. But here's the crux of it. You also need this thing called effective tension. Now, I don't know if you know this, but a guitar, the average guitar, anybody have a guess? There's a certain amount of force on this neck. Anybody know what it is? Anybody? There's no guitar players here. There's approximately 200 pounds of pressure on this wooden neck right now. Which is how this guitar, that's close enough. Relatively in tune now. There's some harmony. I bring this up because this meeting is really designed for harmony. It is designed for us to be harmonious. And that requires the things I already mentioned. We need to tune, just like this guitar. We need to tune to one another. We need tools in order to do that. They are shared tools, collaborative tools. I always bring this case with me when I play. I gig a lot around here in Minneapolis, and I have a lot of tools in here that enable me to stay in tune, to stay plugged in, to make sure my pedals have batteries. I have little screwdrivers to fix things. We need tools, and we need to tune. And in order to do that, we need to hear. Anybody ever play music together, sing in a choir? You're not listening. You can't do it. So we need to hear one another. We need to listen to one another. And we need to hold each other in some relative effective tension. That means everybody in this room has a different view of why we're here and what we are doing and what the standard is that we're trying to tune to. And that requires us to flex. That requires us to challenge each other a little bit so that we can share the same view or get towards the same view. Does that make sense? Okay. That's what this meeting is for. That's why we do it, and that's why there's so many various stakeholders in the room, not unlike the 6 strings on this guitar that sounded terrible, and then it sounded kind of okay. But that's what we're after in this room. And for the next 2 days, that's what I want you to do. Every single person in this room, I want you to listen to each other. I want you to challenge one another and think about what tools we need to stay in tune, stay harmonizing, because it matters to us in the spinal cord injury community. Really, really matters. That's why we're here. That's what we want to do for the next couple of days. And I really want to encourage you to do that. All of you, not just the folks up here at the microphone. We're gonna have plenty of time to discuss and have conversation. And that means you also raise a question, raise a challenge, ask a hard question. Okay? Deal? All right. Thank you. Thank you for tolerating this little business here. Now I'd like to introduce our first presenter, Melissa Miller, who I see close by. Hi, Melissa. Melissa Miller is from the Spinal Cord Injury Research Program. I mean, I'll let you do all the titles. Otherwise known as SCIRP, which is run out of the Congressionally Directed Medical Research Program, run out of Department of Defense. And this morning session is going to be, we're going to hear from people who fund science. First from Melissa, then from Linda Bambrick. Oh, quick thing I forgot to mention to you, little program detail. Linda, unfortunately, due to some health concerns, could not be here today. She was going to be here for we're going to Zoom her in for the panel discussion, but she can't even do that. Well, so we're sad that she's not here and hope that she recovers quickly. And then we're going to hear from Marco Baptista from the Reeve Foundation and Sam Maddox representing Wings for Life. So please welcome Melissa Miller.
All right, is my mic on? Everyone can hear me? Oh, now I can hear me. So hi, everyone. I am Melissa Miller. I'm the program manager for the Spinal Cord Injury Research Program within the congressionally directed medical research programs. And yes, that is a mouthful, and I will be using acronyms for the rest of my talk to make everyone's life easier, including myself. To go along with the rules, I am a 30-ish, don't laugh at that, that's not nice, year-old a white woman with shoulder-length brown hair and a fantastic green shirt under a black jumpsuit. And I have my she/her pin on. Today, I would like to introduce the CDMRP and SCRP to you, highlight what is unique about us, and sets us apart from other funders. We'd like to talk a little bit about how we do the things that we do, why we do it, what we fund, and then, as the talk title alludes to, how we integrate the voice of people with lived experience throughout our process. So the congressionally directed medical research programs, henceforth referred to as CDMRP, is an office within the Department of Defense that implements and manages funding for biomedical research programs. The funding for these programs is directed to CDMRP by Congress, a process that I'll talk a little bit more about later on in my presentation. CDMRP was established in the early 90s as a direct result of advocates petitioning Congress for research dollars towards specific healthcare topics. And in 1992, we had a single program for breast cancer research, while today we manage over $1 billion directed towards more than 30 research programs. Overall, our aim at CDMRP is to transform healthcare through innovative and impactful research. And we do that through responsibly managing research that discovers, develops, and delivers healthcare solutions for service members, veterans, and the American public. Importantly, CDMRP funds research from around the world, meaning that we fund impactful research regardless of where that research is coming from or where that research is being done. For those of you interested in diving deeper into any of the topics discussed today, I've included throughout this presentation some QR codes to make accessing those URLs on the slides a little bit easier. So the Spinal Cord Injury Research Program is one of the CDMRP managed programs and was established in fiscal year 2009. The program aims to be a traumatic SCI research and treatment program with a focus on regeneration, rehabilitation, and long-term care. The vision of the program is to advance the treatment and management of spinal cord injury and ameliorate its consequences relevant to injured service members. And we look to accomplish that vision by funding research that encourages interdisciplinary collaboration for the development and translation of more effective strategies to improve the health and well-being of service members, veterans, and other individuals living with spinal cord injury. So let's break that down a little bit. Although all SCRP-funded research must be relevant to military health, unless specifically stated, it's not a requirement that the research we fund engage only a military or veteran population. The impact of this program is broad, and our hope is to improve health and well-being for all people living with spinal cord injury. So in short, the SCRP challenges the research community to advance the development or translation of healthcare solutions for people living with SCI. We also allow for innovative research that fosters investigation into new areas of research. However, the program favors research that is in a more advanced stage of development. This means that although SCRP invests across the research and development continuum, the majority of our investment focuses on research that has already developed interventions and healthcare solutions. In essence, we want to take those good ideas that were started with other funding and advance those with follow-on funding towards clinical implementation. Another important element of our investment strategy is that the SCRP program funds across the continuum of care from time of injury throughout the lifespan, with a significant investment in topics relevant to chronic spinal cord injury. So finally, to drive research into specific program priorities, SCRP requires that all applications to our funding opportunities address at least one of our 5 focus areas shown here. These priorities were developed with consultation from numerous stakeholders that include researchers and clinicians, but also other SCI research funders and people with SCI. Our intention with these priority areas is to solicit research that address the major needs in the research landscape while also addressing issues of high priority for those living with SCI. So you will see topics like preserving and protecting spinal cord tissue at time of injury, but also investigating psychosocial issues relevant to people with SCI, their families, and care partners. We also have a priority for developing, testing, and validating promising interventions to address bowel and genitourinary dysfunction, which includes both bladder dysfunction and sexual dysfunction post-SCI. This topic area also invites research into pain, cardiopulmonary, and other autonomic dysfunctions. SCRP has a portfolio of over 300 funded awards, but I want to quickly touch on some projects that we are particularly excited about. The first is a project out of Case Western Reserve that's investigating the efficacy of therapy using functional electrical stimulation controlled by an implanted brain-computer interface to improve upper limb mobility. And also restore touch sensation in people with chronic SCI. The first participant in the study received his implant in January 2021, and post-implant continues to regain control of his upper limb. In this picture, he's demonstrating the ability to brush his teeth on his own, something that he could not do for the past 7 years since his injury. And the team is now working on other tasks that the participant has identified as personally important to him, including painting a picture and petting his dog. This project was featured on 60 Minutes this past March, and the link to the video and transcript are included on this slide. The next project comes to us from Stanford University, but is actually recruiting across the United States. This study uses the Vocare electrical stimulation device to improve bladder and bowel function in people with SCI. Now, this device is not new, and in fact has been commercially available since 1982, with FDA approval for this specific indication since 1998. However, the use of this type of electrical stimulation to produce bladder contraction and improve voiding usually is combined with cutting specific sensory neurons to reduce reflex contraction of the bladder and to ultimately improve continence. And as you can imagine, cutting these nerves can have undesirable side effects. So what is exciting about this study is that it's using the stimulator to both produce bladder contraction and block reflex contractions, essentially using stimulation to induce voiding and improve continence, all without cutting sensory nerves. And they've demonstrated that this technique works in a 66-year-old woman living with a traumatic thoracic level SCI who's able to urinate without catheterization and maintain continence without medication for the first time in 41 years since her injury. Finally, we have a clinical trial out of Virginia Commonwealth University that is evaluating virtual reality walking intervention to alleviate neuropathic pain. This illusory walking intervention leverages and builds upon mirror therapies to alleviate phantom limb pain in amputees. The first batch of participants for the study reported meaningful and sustained change in pain perception, and all participants indicated that they looked forward to using the intervention. So this last point is so important because, as you know, that there is a lot of tech out there, but developing an intervention that study participants actually look forward to using may be a real game changer for mass implementation and utilization. So an excellent place to learn more about SCRP, the program, and the research that we fund is through our page within the CDMRP website. There you'll find helpful resources like long-form highlights of our outcomes of our funded research, our program book, which summarizes the program's history, strategic goals, and research outcomes, as well as products that highlight upcoming funding opportunities. There we go. So I've talked quite a bit about what CDMRP and specifically SCRP does, but now I want to talk a little bit, do a little bit of a left turn and talk about how all of this is done, give you a bit of a behind the scenes look. First, let's talk about money. Where does it come from? Well, as I mentioned previously, Congress assigns CDMRP specific programs, and they do this by adding funding on top of the Department of Defense appropriation. So CDMRP funds are not part of the budget requested by the DoD, but rather something that Congress themselves adds to. Each program gets a line item similar to what you see on the bottom left of this slide, which has peer-reviewed spinal cord research and a dollar amount. In this case, we're looking at the appropriation from FY09, which was $35 million. Some programs, like SCRP, also get directive language from Congress that outlines the intent of these funds, defining the focus and boundaries of the program. Many factors contribute to Congress's decision to fund particular programs, but one major contributor are advocates, like many of the people in this room today, who will go to the Hill and advocate for research funds for causes that are important to them. And without advocates' continued effort to bring awareness to important research areas, CDMRP quite literally would not exist. So this is a snapshot of the milestones within the CDMRP annual program cycle, which looks very similar to all CDMRP programs. Every cycle begins with a vision setting or stakeholders meeting, which includes experts in the field, including people with lived experience that are coming together to share information about the SCI landscape and develop an investment strategy for the current year. Applications are then solicited and reviewed through our two-tier review process. I'm walking you through these major milestones of our program cycle because each of these stages, whether they be planning, strategy, or review, include scientists, clinicians, and people with lived experience working together to make decisions and review applications. Involvement of consumers and people with lived experience is a hallmark of CDMRP's processes, and these key stakeholders serve as full voting members on all CDMRP peer programmatic review panels, helping to ensure our programs are addressing the current needs of the community through the research that we solicit and ultimately fund. Additionally, more and more CDMRP programs are seeing consumers and people with lived experience participating in research teams. And in fact, SCRP is one of those programs that is now requiring the involvement of people with lived SCI experience as part of the research team to provide consultation and guidance throughout the planning and execution of translational and clinical research. Our goal for this requirement is not for another box to check by applicants, but instead as a way to facilitate more translational and applicable research for the work that we fund. The entire mission of SCRP is to develop and translate more effective strategies for people living with SCI. And we believe that through equitable partnerships among research and the lived experience communities, we can most effectively accomplish that mission. So if you take nothing else away from this presentation today, I hope that you can appreciate how integral those with lived experience are to the entire CDMRP process. And if you want to learn more about the folks who have served on our peer and programmatic review panels, you can do so on the CDMRP website. And in fact, Jason Stouffer actually has written an entry on the U2FP blog this past May, describing his experience as a consumer reviewer on our peer review panels. So you may want to check that out if you're interested. So I want to finish by noting that you will have the opportunity in this session to hear from a number of funders in the SCI community. So each one of us builds our strategic approach to fund research within the unique parameters of our organization. And I hope I've provided a bit more clarity about who the CDMRP and SCRP are, and I've shed a bit more light on our approaches. So with that, I will end. I'm getting kicked off, but I thank you very much for your time.
Thank you, Melissa. Now, as I mentioned, we're sad that Linda Bambrick from NIH could not be here today. Wish her a speedy recovery. But she did take the time to send us a pre-recorded presentation, so you will hear that from her right now. Thank you.
Thank you. And thank you to the organizers and attendees of this Unite to Fight Paralysis annual symposium. I am so sorry I can't be there in person as planned, but I'm still really happy to have this opportunity to share information on some of the ways NIH supports work on spinal cord injury. Research on spinal cord injury is funded by the National Institutes of Health as part of our mission to learn about living systems and to use that knowledge to improve health. NIH is organized into 27 centers or institutes for different research areas. I work at the National Institute of Neurological Disorders and Stroke. Within NIH, we are the lead IC for most of the SCI research. Both NIH and NINDS develop high-level priorities in the form of 5-year strategic plans. These are developed with public input. You can read the 2021-2025 current strategic plans online and look for opportunities, probably starting in 2024, to comment on the development of the next 5 years of strategic plans. Our current mission statements are shown here, and they're asterisks for reasons I'll get to at the end of this talk. NIH funds research into understanding SCI and improving health for individuals with SCI at academic centers, hospitals, and companies, mostly in the US, but with some international partners as well. We do this by making awards to these sites for specific projects. In fiscal year 2022, NIH funding for SCI research amounted to about $100 million across 214 separate projects. 12 of the 27 NIH institutes and centers fund research on spinal cord injury. As you can see from this pie chart, NINDS in light blue accounts for about 3/4 of that research. But there are significant contributions from other institutes, including the National Institute of Child Health and Human Development, which is the home of the National Medical Rehabilitation Research Center, in there in purple, the National Center of Advancing Translational Science, the Heart, Lung, and Blood Institute in yellow, and the National Institute for Diabetes, Digestive, and Kidney Disease, there in green. And for example, these last two support some of the SCI research on pulmonary and bladder dysfunction after injury. We work together. We coordinate our efforts through trans-NIH working groups and committees. And as program staff, we do talk to each other regularly. I'm going to take a couple of minutes on this slide about NIH SCI funding to talk about how funding decisions are made. In keeping with our priorities, NIH and NINDS put out what we call notices of funding opportunities. A funding opportunity tells a researcher the kind of information they're going to need to provide in order to apply for funds. And this is because what we need to know to evaluate a one-year pilot study is going to be different from what we need to know to evaluate a 5-year clinical trial. So we have different funding opportunities for these different efforts. In general, funding opportunities describe the kind of research, e.g. a clinical trial or a device development project, but in most cases not the disease being targeted. And this means there are not set-asides for SCI research. And this is actually the same approach the Institute takes for most of the other conditions within NINDS, for example, traumatic brain injury or multiple sclerosis. So the first step that for an investigator is to submit an application to a funding opportunity. Then in step 2, the application gets evaluated by a panel of scientific experts. This is called the study section. They rate it for a number of factors, including significance, scientific rigor, and feasibility. The Institute then uses the information from the study section in light of the Institute's priorities to make funding decisions. We do it this way in order to fund the best science. If you think about it, even if an application is targeting a very important problem, if the project itself isn't well designed, it won't be successful and it won't help anyone. And we also do this to help select the relatively small number of projects we can afford to fund. This is a competitive process. We are limited by the funds that we have. NIH funds are allocated by Congress. We can't spend money we don't have. This does mean some good projects may not get funded, but investigators can use the feedback from the review to improve their applications and then resubmit, and many do and are successful this way. But the real take-home message is that this is a very flexible approach, and it allows NIH to fund research going all the way from one-year pilot studies on basic mechanisms up to 5-year multi-million-dollar clinical trials, depending on the quality of the applications received. Of course, this is public money, so what gets funded is publicly available information. We try to be transparent about both the process and the outcomes from our funding. To show you a little of what this looks like, most foundational research on SCI at NINDS is funded through general R01 awards, which can support work from very fundamental questions through early clinical trials. But we do also have a number of awards for projects across the translational and clinical spectrum. And this slide really shows the range of research we can support, all the way from preclinical readiness studies to comparative effectiveness projects. Looking in a little bit more detail, translational research at NINDS includes opportunities for early target model development in the IGNITE program. We also have a growing program for biomarkers, and through Blueprint Neurotherapeutics and Blueprint MedTech, we can support drug and device development. Some of the clinical research opportunities can support exploratory clinical trials. These can be first-in-human trials or studies to figure out mechanisms or the dosing of an intervention. We also have opportunities to fund larger efficacy clinical trials and comparative effectiveness studies. What this means for the distribution of the approximately $100 million in FY22 SCI funding that I showed you earlier is the breakdown shown on this slide. Leaving out some funding for databases and conferences, over half of the SCI funding is for translational and clinical research projects, shown here in blue and yellow. The rest, in purple, is for basic research. And now this slide shows 7 examples of individual awards from the 214 that we funded in FY 2022 to give an idea of the kind of research projects in spinal cord injury NIH supports. In the basic space, we're funding a study of spinal and cerebral biomarkers in chronic spinal cord injury, and a study to try and understand the mechanisms of cortical spinal tract regeneration. Moving into the translational space, we're funding one study that looks to increase the function of those regenerated cortical spinal tract axons, and another on promoting recovery of breathing after chronic spinal cord injury. Then moving into the clinical space, I selected examples of 3 projects. One of them is the restoration of grasp and reach in cervical SCI, another on reducing infection susceptibility by looking to restore immune function after spinal cord injury, and a third on lumbosacral epidural stimulation for restoration of bladder function. And I want to emphasize again that the public can find information on all the research NIH funds online at the website NIH Reporter. Now, besides direct funding of specific projects in SCI, NIH also supports SCI research in several other ways. One of these ways is by enhancing data sharing of results from NIH-funded research. There are a lot of benefits of increased data sharing. Sharing scientific data can accelerate biomedical research discovery, it can enhance research rigor and reproducibility, and promote data reuse for future research studies. Ultimately, the sharing of scientific data has the potential to expedite translation of research results into knowledge, projects, products, and procedures to improve human health. This slide highlights some of NIH's efforts for data sharing. A new NIH policy on data sharing went into effect in January of this year. The policy was developed with public input. Some important changes are the requirement for data sharing, not just publishing results, and the policy strongly encourages the use of established repositories for this sharing. In another effort, we have funding opportunities to support both knowledge and data repositories. And as an example, we are currently funding the Pan Neurotrauma Data Commons for SCI and TBI. NINDS has also facilitated the development of common data elements for clinical spinal cord injury research, and we're currently participating in the early stages of developing common data elements for preclinical SCI research. Using CDEs is another way to help make data in repositories more useful by making it more findable, accessible, interoperable. In other efforts, NIH is addressing ableism, inclusion, and health equity in ways that can affect individuals with SCI. Ableism, as I'm sure many people in the audience are very well aware, is discrimination and social prejudice against people with disabilities and people who are perceived as being disabled. Ableism characterizes people as being defined by their disabilities. It can result in poorer medical care for individuals and less involvement for individuals perceived as disabled in medical research and decision-making, and it's a problem. NIH hosted a 2-day workshop on ableism in biomedical and behavioral research earlier this year. You can watch a video cast of the meeting online and read the summary. We are working on developing and implementing recommendations from this workshop, and Mr. Barry Monroe, who many of you know, was a participant in the workshop, and we really appreciated his contributions. In another effort in 2021, NIH established the advisory committee to the director with a working group on diversity and had, as part of that, a subgroup on individuals with disabilities. Dr. Kim Anderson, who again, many of you know, is a member of this subgroup, and their charge was to dedicate time and resources to identify strategies to support individuals with disabilities. The subgroup issued a report in December of 2022 that had several recommendations, and one of them was to update the NIH mission statement. The report stated that one immediate action for the NIH to support disability inclusion would be to remove the language of, quote, reducing disability, end quote, from the NIH mission statement. The current mission statement, the report says, could be interpreted as perpetuating ableist beliefs that disabled people are flawed and need to be fixed. You can see the proposed change online, and the topic is open for public comment through November 2020 to November 24th. Now, I've mainly talked today about NIH funding for SCI research and a little about data sharing and health equity efforts. NIH does support SCI in several ways other than by funding research. We fund conferences and workshops. Our program staff are available as a resource. We attend conferences, sometimes virtually, and you can also call us and talk to us about research projects or questions. We have a ton of resources available online, both describing funding opportunities and giving guidance on how to apply for and manage a project. The Building Up the Nerve podcast, for example, is particularly targeted to helping new investigators. NIH Reporter is the online resource where you can find information on everything we fund. And the NIH Director, Dr. Walter Koroshetz, whose picture is shown here in the upper left, has letters and recorded presentations available where you can learn about NINDS funding priorities and actions. I have a page of links for these various resources, and Matthew Rodreick has agreed to drop it in the WUVA app for this meeting, so it'll be there for everyone's use. And finally, a thank you for your time. Thank you to all the other funders for spinal cord injury, both those of you who are on the stage and those of you who are in the audience. NIH definitely does not do anything alone. And thank all of you here today, or rather, I suppose there today, for the work you do to advance understanding and treatment of spinal cord injury. Good morning, and I hope you have a really terrific meeting. Thank you.
Thanks to you, Linda, if you're watching. Again, appreciate her taking the time to do that for us. I just want to take a really quick second just to remind you, and I should have probably done it earlier, back to my comments about harmony. The reason why we have Melissa and Linda, and now coming up shortly will be Marco Baptista from the Christopher and Dana Reeve Foundation, and then following that, Sam from Wings for Life. For those of you who haven't read the Navigating the Symposium, this is something we've been trying to do frequently, kind of set the stage for the landscape of spinal cord injury, provide context. In this case, hearing from DOD, SCRP, hearing from NIH, and just really quickly, briefly, just so it's clear, I think you heard it, but SCRP has a roughly $40 million portfolio for research. NIH, it's not standard. It's basically what comes in. And so, but I think the last posting was somewhere around 83 million. But some of that is not for new projects. Some of that is still paying out old projects over a 3-year term or 5-year term. So I think it's important for us, we think it's important to provide context about who is funding research. What is the strategy? What is happening in the landscape? And so that's why we invite these folks to come and talk to us and share what is driving that. And now we'll hear from Marco. Please come on up, Marco, from the Christopher and Dana Reeve Foundation, private spinal cord injury organization you're very familiar with. But Marco's going to share, I guess you could call it a new strategy. Yeah, developing a maturing strategy. Yeah. So please welcome Marco. Thank you.
Hi, everybody. So before I start, I'll give a description of myself. I'm a 5'7" white male wearing a burgundy shirt and a plaid sports coat. It's an honor to be here, so thank you so much for inviting me. I wanted to give an overview, brief overview of the Christopher and Dana Reeve Foundation. We're a very holistic organization. You can see it in our motto, with today's care and tomorrow's cure. So with regards to the care side of the organization, it's been a leader in the field in doing so much within our National Paralysis Resource Center. In fact, if you afterward, you can go out to the booth in the front of the room and see all of the incredible resources that are available. So on the care side, over 120,000 people have interacted with the Reeve information specialists and helping provide for giving needed information for care. There is a peer and family mentor program that has been very effective, and also a quality of life program that has given out over $40 million to nonprofit organizations so that they can help with their communities. On the research side, we're definitely revamping our research strategy. I myself am not an SCI researcher. I come from other nonprofits. I was previously at the Michael J. Fox Foundation for Parkinson's. And the idea is to try to bring in fresh eyes into the field, try to find more ways for us to collaborate and to do even more with the research. So far, we have invested money in research of over $150 million, and I think there's still a lot more that we can do. The reason why there's a lot more that we can do is because there is no FDA-approved treatment for any SCI-associated outcome. So this is a very stark reality. We're hoping that this might change in the near future, but in the meantime, we need to be doing everything we can to de-risk the field. That is the main mission that we have with our research plan, and that is to reduce risk so that researchers can do more work within spinal cord injury research and accelerate the field. Drug discovery, device development is an extremely slow process. There are many reasons for why it's slow. We're in a very good position to try to accelerate the slow process. I think the way for us to get to it is to use this as a metric of our success in making investments in research. We need to have a very robust clinical pipeline. So there is a preclinical stage. There's a stage where researchers are doing work with test tubes and Petri dishes and hopefully having aha moments to then move it to the next stage. And then once it starts to be tested in people, this is a very long, difficult process where safety and feasibility is on the forefront of a lot of these clinical trials. These are very risky things to do because they're very costly and we don't know if it's going to be safe for individuals. But one way that we can, I think, determine if we're having success, we can look to see if we're increasing the number of clinical trials. We can check to see if we're increasing diversity of the clinical trials, meaning not just one drug target, but many different types of drug targets, not just electrical stimulation, but other types of interventions. And lastly, ensuring that the clinical trials are smart. And I use the word smart in the sense that most clinical trials fail. The attrition rate is extremely high. Again, for many reasons, it's very difficult to conduct clinical trials, very difficult to translate the research that's being done so that it's going to be applicable to humans, and trials fail. What you don't want is a trial to fail and you haven't learned anything from that trial. That is absolutely devastating. That's hundreds of millions of dollars that have gone to waste. So to make trials smart, for example, we need to learn more about the biology of the development of spinal cord injury. We need to understand what are the biomarkers that can better place and stratify a population so that you got the right population going to the right clinical trial. In fact, you could have a quote unquote failed clinical trial, but yet that intervention might have been successful if it was in the right population. The only way you know that's the right population is if you're able to understand enough of the biology so that individuals can be stratified and given the right type of intervention. So I think this is a very good metric for us all to use to see if we're having success in the field, because you need to go through these clinical stages. A phase 1 clinical trial is all about safety and tolerability, a small number of people. A phase 2 clinical trial is still safety and tolerability. And then a phase 3, you're starting to really get the numbers so that you can understand efficacy. We've put together a scientific advisory board that I think is quite diverse. and I think reflects also me joining the organization, bringing in fresh eyes. We have individuals like Dr. Kristen Well in the bottom left, who is outside of the SCI field, but can bring a lot of understanding from her area and from all the work that she's done at the FDA. And we have representation of individuals living with SCI that also have expertise of being spinal surgeons. So the strategy can be defined under 3 pillars of research: catalyze, energize, and educate. And these are just easier ways so that you can just sort of remember the work that we're trying to do. Again, everything here is to be a catalyst. Everything is to accelerate, to reduce risk. So under catalyze, we're really looking for both clinical and preclinical projects that have innovative science. They're high risk, high reward. Currently, we have around 7 applications that we're currently reviewing with a mix of clinical and preclinical. And this is work that if we don't support them, there's not going to be any path forward. And a lot of times there might be a really exciting program and a larger investor will ask, well, is it safe in humans? Well, we don't know because we didn't conduct that expensive clinical trial. And this is what we want to try to cover under Catalyze. Under Energize, we really want to be interacting with industry. Industry is not the complete answer to everything, but there needs to be greater collaboration and engagement with industry because they have the resources and the expertise to bring therapeutics across the finish line. Just recently, we partnered with Lineage Cell Therapeutics in La Jolla, San Diego. That was on June 29th. And we got together, over 6 companies that presented on their work, talked about common problems around outcome measures. And it was a very productive meeting. I think we need a lot more of that. We need to try to see if we can repurpose drugs that have been designed for one indication, but maybe there might be some benefits for the SCI community, and we're actively looking at that also. And finally, under Energize, we want to make sure that small companies are doing the type of work upfront that we know that large pharmaceutical companies do. So for example, trying to understand the PK/PD relationship, the pharmacokinetics, what the body does to the drug, the pharmacodynamics, what the drug does to the body. That relationship is crucial to be understood if you're truly going to have translational science and to be able to have success in the clinic. We're going to be launching a request for applications probably in December so that we can support these smaller companies that don't have those resources. And finally, educate. And we just heard from Linda with regards to the open data sharing. The Reeve Foundation is all in for open data sharing. This is absolutely crucial if we want to accelerate research. So the Open Data Commons, which is a fantastic forum that has been set up by other nonprofits, we're trying to further support it. We've given out a grant to an individual at the University of Alberta, so they hired a retrieval data specialist to find data that we know is out there. In fact, probably data that we have helped support and has not been placed. The raw data has not been placed yet in this open data sharing platform. And if you do that, I think things will go faster. New hypotheses can emerge, new preclinical programs can emerge. Science needs to be open. This is a fantastic thing that the NIH has been spearheading, and we fully support that with the work that we're doing under the Educate pillar. And lastly, we need to be giving the right research tools to the community. So for example, there are a lot of preclinical models, different types of assays, ways to measure things that everyone does in their own different way in their own labs. In other indications, these things are a little bit more centralized. They're placed at contract research organizations, neutral organizations that are very open with the protocols, publish the protocols of what's to be done. And now you have a situation where you can, for a fee for service, instead of reinventing the wheel in your lab or big pharma having to figure out how they're going to get their resources redirected towards something which might be more promising for them, to establish a model, it's already going to be established at a contract research organization so that for a fee for service, you can send, for example, your potential therapeutics for them to be tested in an open fashion. So this is the strategy that we're putting into place. We'll be using those metrics of how robust the clinical pipeline will look like to measure. And all of this, of course, is an experiment, and we have to then determine what's the best path forward with this approach. Thank you so much.
Thank you, Marco. Now I'd like to introduce to you Sam Maddox, my friend Sam, my colleague Sam. Sam works for United by Paralysis. I guess probably a lot of you have read some of what he writes. He's our science writer, science advisory board director, but increasingly writes a lot to contextualize the science. But Sam is also a board member of Wings for Life. So Sam is going to come and speak on behalf of Wings for Life's funding strategy and project specifically. Thank you, Sam. Yeah, go ahead. Oh, and one little logistical thing, coffee is back. I know some of you were freaking out. Yeah, thank you. There is coffee service back, and as far as we know, it will be here all day long for those of you who need it. Please welcome Sam.
Testing. Am I on? No? Hello, hello? Coming on? Okay. Hello, everyone. Thanks for being here, coming all this way, some of you. And it's good to be back in Minneapolis. This is a touring show over the years, and it's the home base, so it's nice to be here. I hope I have a pointer here, but anyway, I'm going to tell you a little bit about Wings for Life, assuming that you don't know that much about it because they haven't been as involved in the U.S. Science community as much as other organizations. So, how does this work? There's no green arrow. Oh. Wings for Life started the way a lot of spinal cord injury foundations do. It started in tragedy. It started with an accident. Hannes, kindergartner. I'm kind of wandering around, I guess, like a TED talk. Oh, I forgot. I'm a 6-foot male, gray hair. Not quite geriatric, but not quite not. Anyway, I've been doing this a while. Anyway, so Hannes gets injured in 2003 in Austria. His dad was a famous motocross racer named Heinz. I want to wander a little bit, all right? And so Heinz knew Dietrich Mateschitz. Oh, okay, so it's got to be this. Right? And Dietrich is the founder of Red Bull. And okay, we good now? Sorry. So they wondered, what can we do for this kid? He was 18 years old or so, got hurt in a charity event, racing a motorcycle. And they said, well, they gathered together the science community and said, is there anything that can be done? Because we always hear there's nothing can be done. And the scientists basically gave them the advice, yes, if you work at it and you put some investment in it, there are ways this may be fixable. So in 2004, they started the Wings for Life Foundation, and be 20 years old, I guess, next year. And the United States part of it, the part I'm involved in, the Wings for Life USA, is a nonprofit set up in the States mainly as a fundraising device to set up a charity. And the secret sauce, if there is one for Wings for Life, is that Red Bull pays all overhead, all salaries, all travel, all rent. In 3 offices, there's the one in LA or in Santa Monica, there's one in London, and then there's the headquarters in Salzburg. And this is a pretty significant claim that 100% of all donations for Wings for Life are promoted to the science. And if you've looked at charities 990 and you see what the going rate for a vice president is or a CEO, you can see that adds up to a lot of overhead when you start putting all that together. So kudos to Wings. This is a little bit of an overview. I can hardly see that. The strategy, basically, oh, sorry. I keep moving away from the microphone. It's similar in ways to what NIH is doing in terms of clinical, preclinical, and so on. There you see a picture of Gregoire Courtine, and we'll talk a little bit about some of his work here in a second. So the goal is the cure. There's currently 62 funded projects. I can't read those enough to see what they are, but if you can see those, you can see sort of the breakdown, the areas of regeneration. There's some neuroprotection, very small amount of neuroprotection. Anyway, that chart on the left, lower left, shows that the growth over the 20 years. And it does continue to grow. The fundraising, it does increase every year. Red Bull, they bring together their network. The Red Bull family includes bottlers and distributors, and they are all very generous in supporting the foundation. So it continues to grow as Red Bull continues to grow. I got to be able to read these things. Can I move over there? Can I get a monitor or does that work? I got to be able to see these so I can tell you what's going on. Now, I'm going to tell you about a couple of recent projects, and they're similar because they involve mice, but they involve a developing therapy, but they're quite different. And one of them was presented to us. There was a meeting last May in Salzburg where all the funded scientists from Wings got together in one meeting, and I got to go to that this year. And this woman, I think her name's Monica. Is that? Yeah, Monica Sousa from Portugal, talked about a mouse called Acamis, which it's very unusual. I'd never heard of this before. People study axolotls and salamanders that can regrow limbs. This mouse can repair its skin. It can repair its heart. It can repair its spinal cord after injury. Now, that is a pretty interesting project. So what she's doing is she's being funded by Wings to try to figure out how can we sort of de-engineer that process. How does that animal do that? What's the evolutionary advantage of it? But then how does it work? How do those genes get turned on and all the way through the process? So she's doing that. That's purely basic science. Now, where'd that go? Okay. Now, this is another mouse study that just came out about a month ago, and I think it's really interesting because we may wind up talking about this in the regeneration sessions later today. But this is an acute mouse study that basically what this team has done, and this team is widely funded. A number of these people were funded by Wings. It's basically the two main labs are the Cortine lab in Switzerland and the Soffernu lab in UCLA. But what they did was they decided that, look, we need to turn on the regenerative process similarly as it was when we were forming our nervous systems the first time. And how do we do that? Well, you have to get the nerves to grow. You've got to get them to grow with the same kind of robust enthusiasm they did in the first place. Then you have to give them something to grow on. You've got to give them a structure and a nourishing and perhaps a scaffold, and then you have to direct them. Now, so this is all sorts of combinations. Here we're going to have, there's going to be some electrical stimulation in here, some nerve reprogramming, genetic nerve reprogramming. And then in earlier studies, they've actually used cell therapies to try to get the environment of the scar area ready for growth. But this is a really interesting story because it sort of challenges other dogma as far as the inhibition of growth. What's going on? Yeah, I'm hitting the green. One more. Okay. Now there's another program at Wings, Accelerated Translation Program. The first program I talked about was basically individual grants. Those are usually 3-year grants, 100 grand or so a year. These grants, the ATP program looks at filling these gaps between basic research and clinical research, and then clinical research to commercial development. And I'm going to look at a couple of these. Yeah, okay, here we go. Okay. Now, this is ATP funds are, it's a separate review process. It's run through the Austrians, and it doesn't have a set budget or even a set timetable. Whatever, if something comes along, they'll fund it. Now, for example, here's 4 recent examples of ATP projects. Some of them we've been following here over the years with presentations here. This is Michael Kilgard. He was responsible for a study of the vagal nerve stimulation. That's actually a stimulator in the vagal nerve here that is moving towards clinical application. It's already been approved for stroke. So another one is neuroprosthetics. That's the Cortine stuff. Axer 204, Renetics, that's a clinical trial that was funded at about $8 million by Wings. And I wouldn't say it's a failure because there's something being learned from it, but it didn't succeed in meeting its endpoints. In other words, there's some slimmer, there's some data that might be extracted that's going to be useful, but as a trial, it didn't really work out. Now, the one we're going to talk about here is the NerveGen trial, which we're all familiar with. Jerry's presented here many times, and he talked about this very study a couple of years ago. Basically, he's discovered a molecule that helps break down the impediment to axon growth, and it worked in animals, and it worked really well. The animals recovered a lot of function, and they all recovered bladder function. And now there's a company, NerveGen, and NerveGen got a grant of $3.2 million from Wings to make sure that it goes into a clinical trial. And the clinical trial is now enrolling at Shirley Ryan. There are going to be 20 acutely injured and 20 chronic injured will get this drug. It's given intravenously. And it's being directed by Monica Perez, who I think presented here last year. This is a picture of our science group in Austria. No reason to, and then another thing Wings supports clinical trials resource, SEI trialfinder.net. Dial in your information, where you are, what your level of injury is, and your details, and you can look up all the clinical trials for what your condition is. And then lastly, the big fundraiser in the United States. That's actually the big global fundraiser for Wings. It's called the World Run. And this is a race where the catcher car comes to you. In other words, you don't run to the finish line. The finish line runs behind you and catches you. This happens every year. It's the same time of day all around the world. It's 4 o'clock in the morning and where I live in LA. And it's really quite an amazing, it's really cool. And so next May 5th, 2024 will be the next World Run. And so I don't work for Wings. I'm happy to answer questions about what Wings does to the extent I know of it, but I'm not involved in the scientific review process itself. But I can tell you it's very rigorously reviewed and it's a very serious effort to get after spinal cord injury on many different fronts. So thank you very much.
Yeah. Marco, Melissa, will you all come up? You can. Yeah. And as I mentioned, unfortunately, I'm still kind of broken up about it. Linda Bambrick is not able to even zoom in for this part of the conversation. But this is an opportunity for you to ask some questions of these folks. Sorry, that side of the house can't see. I will move that for you. Yeah, we actually talked about that. Better? Yeah? Excellent. Okay. Oh, hands up already. Kristen, we need some microphones though. Oh, excellent. Oh, go ahead, Jason. Is it on?
Hello. Oh, there we go. I'm Jason Biendo. I'm a research assistant in Jigong He's lab at Boston Children's Hospital. So I'm a young investigator starting my career in spinal cord injury research. I'm involved in the DoD research program as a reviewer, and I'm about to apply to grad school to get a PhD and continue doing spinal cord injury research. But when I talk to other people, it's really hard to get them interested in spinal cord injury research. If I wasn't injured, I probably wouldn't be here. And so how can we continue to support young investigators, encourage them to get into spinal cord injury research? Can we get some more fellowships for graduate students, especially graduate students? I know there's some for postdocs, but I haven't seen a lot for graduate students, especially in spinal cord injury research. Really encourage them to see this field as an opportunity. Like, I talk to people in my lab, and it's hard to even get them to continue in spinal cord injury research, even if once they've actually started. It's a hard field to get started in. So I think a lot of funding for young investigators would be great.
I have bad news for them, so I don't want to start.
Bad news. But I appreciate those comments. I think there is a need to just be generating more and more interest in the field. I think there's a direct way of doing it. So ways that funders can support young investigators, I think, is really important. In showing our scientific advisory board, I made sure that we had junior investigators that were on the board so that they can provide their perspectives. Ultimately, I think, and it was a big reason about why I joined the Christopher and Dana Reeve Foundation, is that I was just seeing really exciting, innovative science happening, and it's changed considerably. I think 30, 40 years ago, there was this mentality that this there just wasn't going to be any progress. And that's changed tremendously around, I think specifically around electrical stimulation, to the point that we might see something get approval next year. I think indirectly, that's the way to really get more and more people excited about it, is to do everything we can to bring these really exciting therapies to individuals.
So from a DoD perspective, we don't have the capacity to fund fellowships, for example. We fund the development of products. However, you're sitting right next to a rep of a foundation that funds very heavily into capacity development and maintenance for the spinal cord injury field. And I think that that's really important. One, capacity building and maintenance is incredibly important. And providing funds for early career investigators, also important. But how other funders like the DoD can contribute in other ways is also by demystifying our processes, by including early career investigators in our review and strategic planning processes, so that it is not so much of a burden to jump in and apply for our awards, because they've already seen the process, they've seen the review, they understand. And so there's certainly we can't fund, for example, graduate students. However, we can help sort of build capacity in other ways.
Naomi can respond.
Before we give the microphone to Kristen. Hi, for those of you who don't know me, I know many of you, but I'm Naomi Kleitman from the Craig H. Nielsen Foundation. So just if you were wondering what all that hand waving was about. So we also fund in this space and are partners with many of these organizations, including Wings for Life and researchers at Mayo and other places around here. I just want to also point out Kevin Lewin is here from the foundation and will be here the whole meeting. So if you have any questions about what we do, please feel free to.
The Argyle sweater right there. And I also want to answer, Jason, you'll hear a little bit more about this tomorrow, but this is a question that we in the advocacy community have raised quite a bit, and you'll hear about the state funding program that exists here in Minnesota and that we helped pass in Ohio and Pennsylvania, and soon we hope in Wisconsin. One of two things. One is that program has funded young investigators, has started projects that wouldn't have been funded elsewhere through a state mechanism. So in Minnesota, we have $6 million appropriation. We'll tell you the whole story tomorrow. But the second part is we have constantly been asking that question. And in Minnesota, actually, and we'll maybe talk about this, Rob, you remember, we wanted to include a portion of the dollars here to entice young investigators to get into this field. We weren't able to work it into the statute, but we've been talking internally. There's what's called an Upper Midwest Compact for higher education. It's many states in the Upper Midwest, and we think we can start, we're hoping to do this in Wisconsin, start utilizing this as a tease to the state's higher education program to say, hey, we want to help young people get into this field that is advancing rapidly, and there's some real innovation. So I just want to mention that, and we'll talk more about it tomorrow.
Do you mind if I make one additional comment?
Yeah. Go, please.
Because yes, money is important, but also doing the research easier will help also draw new people into the field. And I think what the Christopher and Dana Reeve are doing to help facilitate contracts and sort of the ability to outsource a little bit of that science to contract organizations will also help try to bring more people into the field.
Kristen.
Okay, my question's going to be a little more disruptive, I think.
Oh, please.
Love it.
Oh, I'm sorry. Kristen Zhao, Mayo Clinic. So I guess I understand the kind of emphasis on pushing trials to translate some of these interventions to help patients with spinal cord injuries. I also understand, though, that from like the SCI 2020 meeting, we talked a lot about advocates and participants and what they want to have happen in a shorter time frame than that, right? So can we come up with a mechanism that will do both, right? So we're not just funding a drug trial or a device trial, but we have outcomes that also are giving participants information in real time in a more clinical fashion. So for example, if you're in a spinal stimulation study, what can you learn about yourself and your injury and whether you respond? You know, these are things we think about in our clinical institution, because if we don't give them that information real time in research, they're going to be going to our clinicians next and saying, well, now I did this trial and I sort of saw that thing and it doesn't do what I want. And I really want to know something now. I don't want to wait until, you know, this trial gets to the end 7 years from now. And so we see that every day. I just wanted to just pose that as like, what mechanisms can you come up with? You know, not just taking input from participants and advocates, but, you know, what can we give them now? And is there a mechanism for that? Because when I write a grant, I don't feel like anyone wants to hear that, right? I mean, in real time, we want a mechanistic trial, exploratory trial. We want a device to the FDA. Those aren't really short-term returns and outcomes. So I know maybe I'm not hearing it right, but that's part of the disruption, I guess, maybe. Tell me I'm wrong.
Well, so from our perspective, I think part of requiring people with lived experience to collaborate with investigators is to provide such feedback, right? We want, as funders, to know what feedback you are planning to get from those individuals, as well as how are you going to feed that back into your research and make that research study better. I don't know that we absolutely are interested in hearing about how you are going to feed back the information that you receive to the community, whether that be on an individual basis, or whether that be on a broad spectrum. So that information and that style of feedback is absolutely encouraged and noted in our program announcements as something we want to see.
Murray.
Yeah, Murray Blackmore. I'm a research. I'm a professor. So this has to start with a thank you, right? Thank you to the taxpayers. Thank you to our kids and grandkids, because a lot of this money is borrowed, and I guess the idea is they're going to pay it back. You know, all the work from the foundations. But when you stack it all up, in the past, I don't know, say since the turn of the century, it's going to be in the low billions with a B, a total investment, like as a species, right? And what I would love to get is just a read on your level of satisfaction or frustration. So if I can, I'd like to put you on the spot. If each of you could just give a letter grade, not of your own foundation, or your own organization. But if you just step back and look at 20 years of investment, and you know, F would be we might as well put the money in a pile and burned it, and A+ would be like flawless execution. We are exactly where we should be with billions of dollars. Can I just get a letter grade from each of you? And Naomi, if you want to jump in too, that'd be great.
I know, maybe I can start the letter grade. Again, I'm new to the SCI community, so curious to see how my letter grade matches with everyone else. But I would probably say it's a C+B, and the reason for that is that I'm seeing great science, but still gaps in the way that things are going to be translated. So for example, I think the complexity of SCI injuries are so great that there needs to be that really big push. And I mentioned about having a smart clinical trial of really understanding the biomarkers, you know, the indicators. Like if you were to go to the doctor, a biomarker could be cholesterol, it could be your blood pressure. You know, these are things that are lacking in the SCI field. I think that's detrimental for there to be success. I think that's why you don't see things happening quickly, because people can go all in with a lot of funding with a clinical trial, and then it's going to fail. There are great people doing amazing work around biomarkers. You know, like Dr. Kwan is doing just tremendous work around that area, just from a, you know, fresh eyes perspective. I think we need to really double down on something like that, or we're not going to get to the place we really want to be to have translation. So I think the complexity of the injury is not. We could do a lot better, I think, in how we collaborate, how we organize ourselves to be able to really better understand biology. And then when we're really talking about translation, we really have to talk about who are the right stakeholders that are going to be in place to do the translation. So, and I'll be very open. If I hear a talk around animal models of genetics, then I would think not too far along in one's research. Maybe you're not doing it in your own lab, but you should be seeking out the other groups that are experts on it. Figure out if those same genes that are upregulated in an animal model is upregulated in a human. That should be done. You shouldn't wait 10, 20 years for that to happen. And I think this is just an issue of we need to work together better. So that's my take on it.
I would grade, when you get a grade, C used to be sort of like satisfactory. I don't think we're satisfactory. So I can't give a solid C, but D sounds a little harsh. D sounds like, wow, we're not really doing a very good job. And in fact, we're not very efficient about a lot of the ways this money's spent. And there's a project being undertaken now to actually look and try to count up all the money that's been spent on spinal cord injury in the last 20 years. Well reviewed and sort of rigorous study. And it's going to be shocking, I think, to see the kind of money that's been spent for so little result. So I'd have to say, I'm going to be generous and say C-.
So I'm going to, Sam showed a very, I think, great representation of what I want to say, which is that multi-peak, two bridge translation map, where we have that translation from bench to clinic or clinical research, and then clinical research to clinical implementation. And I think to be able to give a grade, we need to grade both of those. So I think that we are doing okay in certain areas, taking the basic science and moving it towards clinical research. So I agree with that we're in the C. It's not good, but it's not that bad. We have pathways. However, in that second bridge, that translation from clinical research to clinical implementation, I'm giving us a failing grade. We are not good at that. I don't know that any field is good at that, but I think that is where we have a lot more growth that we need to do to be able to make what we up here are doing in the research space really move to the people who will be using this research and products.
Naomi?
So again, Naomi Kleitman. I didn't introduce myself visually before, but late middle-aged woman, Black with colorful blouses always and brooches, and probably the only person here close to Sam in terms of length of time in this field, trying to make it as real as possible. When I moved out of my cell biology lab, I read Sam's Spinal Network, and that's the reason I'm here today. So the other thing is we do a lot of reviewing, and I'm surprised because in any of our review committees, for all the reviewers to end up with a C+, C- range, that would be really unusual. But that's where I would start. But I'm old enough that when I was a kid, we not only got those grades, but we got an S for satisfactory, an E for makes a lot of effort. The thing I would give spinal cord injury as a field, compared to all the others I've been exposed to, is a high level for effort. I think that for a long time when I started, it was all about true regeneration and get those cells growing exactly where they were. Otherwise, it's not real research. And in the last 30 years that I've been in the field, more than a lot of the other 600 or whatever diseases, disorders in neurology that are funded, for instance, by NIH, spinal cord injury has taken that leap to saying, let's talk about what's real for the community. Let's think about devices, not just regeneration of cells. There's been a huge amount of progress in terms of doing some of those things. And when we look at, for instance, what the functional stem and the epi-stem devices are doing today for people, not yet as that's what every person with the injury should get through their medical program, but to have made that leap. That's the reason I'd give it a little higher for effort. And that's the thing that will continue to drive us forward. It's this conversation we're having that I think makes this field particularly more unusual. And in terms of speaking as one of the funders, having worked with Melissa and Linda over the past, gosh, I don't know how many, 8 years, we've been communicating with each other what we fund. We communicate with Marco. We talk to Wings for Life. We tell each other how to cover the whole range of things. And of all the CDMRP programs, we were one of the very first ones to do that as well. So that effort moment, and it's a great question, Murray, it really is. We need to keep that effort going.
I know you didn't ask me, Murray, but I have to answer. Sam gave an allusion to it, but I think it's really important because I think part of the problem here is that it's very hard to grade this because it's very few people know what's happened. Where's the money gone? Where does it come from? Where are the priorities? And Sam mentioned, so we reached out to a researcher at Texas A&M a number of months back, along with a handful of people with SCI. We're actually fairly deep into this project of looking at the last 10 years of all the funding in SCI. Publicly available, privately, there's some work to be done, but part of it is to understand what's happening. And because I think if you had different groups of people around different tables, if you asked researchers, and this kind of gets at your question, I think, is sort of like, well, who has different rubric for grading, right? Does a person with spinal cord injury have a different perspective than a person with research experience, than a clinician, than a venture capitalist, right? And I think they're all different. But one thing that's clear is that very few people have a really good handle on what has been done in the last 10, 20, 50, 100 years. And so I think it's really important for us to understand that, which again comes back to what I mentioned at the front end. That's why meetings like this are important. That's why meetings like this with a lot of variety of people are important, because there's differing perspectives. And those perspectives have to come to the table in order for us to have an appropriate grade, right? I know we have one more question. I'm sorry for some of you. Daniel, it's from the live stream. Please go ahead.
Yeah, we have a question from Jared Kerr from the live stream. It's for Melissa. The bladder stimulator that was showcased, is it commercially available? And how does the CDMRP share its medical device breakthroughs while honoring patents? Similar question about the NIH-funded research, if anyone else knows as well.
Sure. So yes, that's the Vocare system. It is commercially available. It's commercially available. It's not, and it's not. Okay. In the UK, it's commercially available. Yes. Yeah. Okay. So I would just want to make sure that I'm speaking about the right country. Yes, it's not available. It is not commercially available in the US. It's commercially available in the UK. The question about how do we highlight our research while being cognizant of patents. So that's a very good question. So when we our researchers have to will indicate whether the information that they inform us, they report out on, is able to be publicly disclosed or not. And so we work very closely with our researchers to make sure that what we are presenting out into the world, publicly available, that we make publicly available, is within the what is allowable with them, their tech transfer offices, as well as our public affairs office, to make sure that we are not disclosing anything that we shouldn't be disclosing relevant to patents.
May I make a comment about that? Because I think these things are not mutually exclusive. I think you can do everything to protect one's intellectual property, which is incredibly important if you want something to cross the finish line and make it as a therapeutic. But at the same time, I think you can find a lot of space where you're still protecting intellectual property, but working with a partner and other research tools that they might have that we know are not going to be the clinical candidates. They're not going to be advanced, but can be powerful tools in understanding biology and understanding safety, and they can be used. So you can still have open data commons and a lot of data being shared and open, and still protect intellectual property.
All right, thank you. That's all the time. I'm sorry. I know I pointed to you guys like we'll give you a question. Sorry. It's time for a break. Thank you for your patience. Thank you all for sitting and presenting, entertaining questions. Couple quick logistical things. There is food out there now, I'm told, I hope. I don't know what it is. Could be grasshoppers, could be, yeah. But help yourself. One little point, for the next session, just so you're aware, the banquet folks are going to start coming in, giving you silverware and plates in preparation for lunch. So just don't be distracted by them. But they'll be coming in. So take a break, get a breather, and then we'll come back in 30 minutes. We'll wave you back in. Thank you.